So a topic dear to my heart, and I'm perhaps going to take you through areas that you had not considered testosterone to be important for. And if I can have the next slide, and I need the...
For the slide,
It's gone. My slide, we're having real fun here today, aren't we? Have you got it in your pocket, Alfred?
No, it was here.
Okay, whoever's got the...
wait, please.
This is a trick session. So can we just advance the next slide, perhaps? So my potential conflicts are listed there, and as you can see, most of my research funding is from competitive grants. The next slide, please. So when we talk about, thank you, sex steroids, when I studied medicine, what we learned was that there was a lock and key, that the steroid went into the cell and bound to the receptor, and that was it. But we now know it's much more complicated, that the action of sex steroids, we tend to measure sex steroids and think that that's the level that matters, but we now know that sex steroids can go through membrane-bound receptors and activate protein kinases, and that they can also act through G-coupled protein receptors. So, in fact, a hormone's action is not simply modified by the amount of hormones circulating in the blood, but rather is modified by the receptors it's working through, the presence of coactivators and repressors, transcription factors, and the concentration of other steroids in the cell, which will cause upregulation and downregulation of receptors. So when we measure a hormone in the blood, like testosterone, and we're saying it's too high or too low, we're really using a very blunt tool to estimate what's happening in a highly sophisticated setting. Now again, this is the slide or the picture you're almost familiar with, that androgens are produced by ovaries and adrenals, androstenedione, testosterone, and action through either conversion to estradiol or direct actions through the androgen receptor and other modalities. But we now know that that's, again, a fairly clunky view of testosterone action. And in fact, again, I've here depicted the traditional testosterone pathway that we understand, but some very elegant work over the last few years has shown that there's another pathway that has been identified. So originally, the oxygenated steroids were only considered to be present in marine life, but recently have been found in humans and notably in women. And in fact, the final products, 11-keto-testosterone and 11-keto-dihydrotestosterone, which are non-aromatizable androgens, actually are found in greater quantities in the female circulation than androstenedione itself. So you've all seen the patients who are hirsute, but you measure their androgens and they're normal. And these, in fact, may explain the missing link between androgen phenotype in women and what we haven't been measuring in blood. And these are also very exciting opportunities to better understand a whole range of conditions in women. So when we talk about androgen production in women, it's now extremely complicated, and I would commend this paper to all of you if you're interested in this field, because it shows you the classical pathway in red. It shows you the oxygenated steroid pathway that I've just mentioned to you that needs much more investigation, and what's also called the backdoor pathway of androgen production, shown here. So my point here is we measure testosterone in women and say it's high or low, but what we're measuring is so simplistic in the complex field of androgen action. So then it gets messier. So low levels in women are a challenge to measure. There's imprecision of low levels. there's cross-reactivity with DHEA sulfate. So I was really not very pleased to learn that up until about 10 years ago, the measurement of testosterone in any of the radioimmunoassays we have used, even the published papers I have done, highly cross-reacted with DHEA sulfate. So much of what we've been measuring up until the last 10 years was DHEA, not testosterone itself. And the normal ranges are based on very small numbers of women. When testosterone is more than 4 nanomoles per litre, there's good correlation between the radioimmunoassays and mass spec. When testosterone's less than 4, basically along the lines of what was suggested years ago, clinically a good guess is probably as good as the assay. And finally, when we talk about low androgens, please don't use the free androgen index. That's fine for measuring higher androgen levels, but it is not a good estimate of low testosterone in women. So there is no diagnostic cutoff for any of the androgens for any condition for describing low testosterone. That's the only thing you remember from what I've said. It's the most important fact to leave. You cannot diagnose low testosterone women by a blood test. So why do we measure it? To avoid treating women who have high testosterone, if we are going to treat with testosterone, to avoid treating women with high sex hormone binding globulin, because we have shown in various studies that if a woman has a very high SHBG and you give testosterone for, say, low libido, it won't work. And if a woman has an extremely low SHBG and you give testosterone, it will be cleared rapidly into the circulation. So that's why we measure hormones, or these hormones. So what's low? Well, testosterone is really important in the female reproductive cycle. The levels increase at ovulation and remain high through the luteal phase. So when is testosterone low? It falls, both total and free testosterone fall with age in healthy women, with the greatest reduction being premenopausal, and does not change across the menopause transition with natural menopause. So when testosterone falls, it falls before menopause, predominantly. Women with ovarian insufficiency, I'm an endocrinologist, I do not take out ovaries, but my colleagues, many of you are gynecologists, and if you're removing a woman's ovaries, or if you're suppressing ovarian function with the oral contraceptive pill or a GnRH agonist, you will remove about 50% of her testosterone production. If a woman has adrenal insufficiency, and people like me who give prednisolone for various conditions will actually suppress 50% of the peripheral testosterone availability. And for women who are hyperpit, they basically are testosterone deplete. So going back to follicular genesis, testosterone is important for women. If you don't have testosterone, you don't make estrogen, and you don't have reproduction. And here you can see the association between testosterone level and follicular size. And a number of studies have looked at poor responders to IVF and have shown that women with low testosterone may actually have lower fertility, and this is various studies that have looked at treating women with testosterone and shown a consistent increase in reproductive success with testosterone pre-treatment to IVF with fairly good consistency between the studies. What about musculoskeletal health? Well, testosterone is an important precursor for estrogen in bone and has direct actions in bone. Slemender published this many years ago, and he looked at the loss of bone in premenopausal women and showed that the highest correlation between premenopausal bone loss and hormones was between lower free testosterone and bone loss from the hip. This is a model looking at a number of older women at their hormone levels and at their bone density, and in the black is free testosterone, the light color is total testosterone, lumbar spine and total hip. And here you can see in this model that there is a strong correlation between testosterone levels and bone mineral density in older women, with the idea that if you know their testosterone, you can theoretically predict their bone density. Older women with higher testosterone levels are less likely to fracture. So again, is this the testosterone, or is testosterone a biomarker for other parameters of good health? So these are observational studies, and they indicate an association. They do not show that it's a causative effect, but certainly as a biomarker, testosterone is associated with greater bone strength in older women and less likelihood of fracture. So the odds ratio of fracture with a higher testosterone was lower. This is a small study we published years ago where we treated women with either estrogen implants only or estrogen plus testosterone, and to trick you, the estrogen plus testosterone is in red, not blue. And you can see that we saw a significant improvement in trochanteric and lumbar spine bone density when we treated women with testosterone as well as estrogen. There is no absolute fracture data from clinical trials of testosterone in women, so it cannot be recommended to prevent fracture at this point. And what about muscle mass? Well, women with lower testosterone, this is a Japanese study with an 8-year follow-up, are more likely to lose appendicular mass, more likely to develop sarcopenia with age. So testosterone improves body composition in terms that it's been shown in studies to increase lean body mass, and particularly in hypopituitary women, and it's also associated with a lower percentage of body fat. These are clinical trials. And this shows you Karen Miller's beautiful work showing that testosterone replacement in hypopit women who are estrogen replete shows a significant improvement in lean mass over time. What about cognition? Well, I won't go through this in detail, but there is evidence that androgens may have an important role in maintaining cognitive function and, in fact, reducing amyloid deposition in the brain. So high levels of testosterone in elderly women have been linked to superior performance on verbal fluency and in verbal memory tasks, endogenous levels I'm talking about, and higher levels of DHEA sulfate as a precursor is favourably associated with executive function, concentration, and working memory. Now, we did a series of studies where we treated women in a placebo-controlled study with estrogen versus placebo, and then a parallel study with testosterone. And we did functional brain imaging, so women performed tasks in the scanner. And we found that women treated with testosterone had a significant improvement in verbal fluency, they performed the verbal fluency with treatment with testosterone with less recruitment of neurons in the brain. So at 6 months, they were able to be more active in their brain activity with less recruitment of brain areas. And with the mental rotation task, they performed in the same manner compared to baseline with less neuronal recruitment, but they performed more complex tasks more simply. And in this double-blind placebo-controlled trial, we looked at a range of computer-based testing of cognitive function over 26 weeks. And it doesn't seem very much, but the women treated with testosterone had, in terms of verbal learning and memory, a consistent mean improvement compared to placebo of 1.57 words on the task. That seems trivial, but these women are not cognitively impaired. And this degree of improvement is accepted by the FDA as a significant effect of drugs to improve cognition in people with cognitive decline. So this is a clinically significant improvement, even though it seems small. So we have shown that testosterone may improve cognitive function in women. What about cardiovascular health? Observational studies in women of an average age of 58 years show that lower testosterone predicts all-cause mortality in cardiovascular events. And this is work from Gail Loughlin's group in looking at older women with baseline testosterone measured many years earlier, showing that women in the lowest quintile of total testosterone have increased incident coronary artery disease. She also found that women with the lowest quintile and the highest quintile of bioavailable testosterone had the highest incident of heart disease, but if you had a more normal testosterone, you were at least at risk. And similar in diabetic women, women with lower testosterone levels are more at risk of all-cause mortality and also cardiovascular death. So this is a study. How does testosterone work in the heart? So this is my this is mouse-reported study. So these mice were either sham-treated, oophorectomized and estrogen, testosterone, or estrogen and testosterone. And I'm just going to go through briefly. They were treated, they were sacrificed, the hearts were immediately put on a model where the arteries were ligated, they cause immediate ischemia, and then they reperfuse the heart. So it's a model for a cardiovascular event. And what they found was, and really the bottom line is over here, that these are the sham ones that show the response with reperfusion. If you oophorectomize them, you have a really bad cardiovascular event. If you treat them with estrogen only, not much happens. But if you treat them with testosterone, they have a less severe event. And if you treat the animals with estrogen plus testosterone, they're no different to the shams. So estrogen plus testosterone basically restores these animals to a sham status, whereas estrogen only does not protect their heart sufficiently. How does it work? Well, you look at LDH in the coronary effluent, and less LDH is a marker of less damage. So remember that cardiologists measure LDH as a marker of damage. And the animals that are treated in this particular study that got testosterone plus letrozole blocking conversion of testosterone to estrogen had the least myocardial damage. And in the same study where they treated animals with oophorectomy, letrozole, and testosterone, you got the greatest increase in phosphorylated AKT, which is associated with enhanced cell survival. So the take-home message is testosterone seems to protect the myocardium in mouse models of ischemia. What else does testosterone do? Well, it's important for action potentials and repolarization. So women with having a very long repolarization phase puts you at greater risk of arrhythmias. So men have faster repolarization rates than women, and women with high testosterone actually have faster repolarization. So there is evidence to suggest that a low testosterone state may actually promote heart failure and reduced ejection fraction because of impact on cardiac repolarization. Very quickly, vaginal health. There are androgen receptors right throughout the vagina. And women who are taking testosterone for female to male transgenders have an increase in the androgen receptors in the vagina, and postmenopausal women have fewer androgen receptors in the vagina than premenopausal women, and the vaginal androgen receptor levels decline with age. There is evidence that testosterone and higher androstenedione are actually associated with less vaginal atrophy, and this is work from Sandra Lieblum from many years ago. If you want to know more about testosterone and vaginas, I suggest you go to the presentation by Professor Robin Bell Friday afternoon. And for testosterone and sexual function, well, you think I'm going to talk for 20 minutes? I'm actually going to say nothing, because if you want to know anything about this, you need to come and listen to Johannes Bitzer and myself debate this issue tomorrow. So in summary, low testosterone is an issue for women. It is an important female hormone because we can't make estrogen unless we have testosterone. It's important in reproductive health, in musculoskeletal health, potentially in cardiovascular risk, potentially in cognitive function, and as I said, for the vaginal effects and sexual function. Please attend the other sessions, and thank you for your attention.
Thank you. Thank you very much, Susan.
Oh, sorry, the most important slide.
Good morning, Chairman and colleagues. I'm very honored to be together with you, give my presentation. Just now, Professor Susan Davis gave a high scientific lectures. Now I give you more practical. Is when estrogen is too low is a problem, but if androgens are too high, also problems. I will focus on PCOS patients with hyperandrogenism. Professor Xiangyan Ruan comes from Beijing, China, Capital Medical University, Beijing Obstetricals and Gynecology Hospital. I have no conflict of interest. Today, I give you more practical things because in my hospital, every day, more than 5,000 outpatients. My department, gynecologic endocrinology, every day we have more than 500 outpatients. Last year, we have more than 10,000 outpatients. These patients, so many patients, the PCOS patients occupied more than 50%. In my PCOS patients, more than 80% of PCOS patients with hyperandrogenism. It's all my patients. For young girls, they visited the high androgens was a problem. For young girls, they visited our clinic is for acne, hirsutism. For this reason, also often made them depression. Also, is this different signs for hirsutism. It's sign of excelsis and negligence. Also, some patients visited me for alopecia. It's sometimes one family, two patients, mother and a daughter. You know the PCOS patients have some genetic reasons. They are obese and abnormal uterine bleeding. Some patients, obesity and severe hypertension need to go to the special hospital. For reproductive patients, most patients visited my clinic is for infertility. You know, 80% ovulation infertility is PCOS patients. Why? Because extra-ovarian factors and the intra-ovarian factors lead to the PCOS patients' poor eggs and poor embryos. The normal ovarian tissue is follicles. This is from our China, our first ovarian tissue cryo bank. You know that it's the bread point is normal follicles. If the PCOS patients, the ovarian tissue, you can see the follicles is very rare. The 3 millimeter corticals ovarian tissue, just 6 follicles. Some patients, when the PCOS patients with hyperandrogenism, when got pregnancy, also have pre-eclampsia. So PCOS patients impact women's health of life, the young age menstrual disorder, and bleedings, hirsutism, and infertility. When older, the pregnancy complications, and the quality of life, diabetes, and cardiovascular disease, and endometrium cancer risk also increased. What's the reason? I think it's very complicated. The pathogenesis of PCOS, I think most thing is testosterone, increase testosterone levels, and also insulin resistance. Women with PCOS had a greater prevalence of overweight and obesity. Some places more than 80%. But Asian women with PCOS have greater risk of central obesity. You can see the risk is more than 2. Comparing on lipids in obese and non-obese PCOS patients, you can see the obese patients, HDL is low. HDL is low and TC is higher. SHBG is correlated negative with BMI in PCOS patients. And obese PCOS women got lower clinic pregnancy rate. You also can see obesity has a negative impact on the outcome of pregnancies, abortion, stillbirth, and congenital abnormality. How to lose the obesity is important impact for patients, but how to lose weight is the bigger problems. We know that Orlistat is an inhibitor of a special lipids. It can block 25 to 30% fat absorption. The Orlistat, for other literature, we can see Orlistat reduce total testosterone in overweight patients with PCOS. The blue bar is before treatment. The yellow is after treatment. The treatment group and the control group, you can see, is different. For the PCOS patients with hyperandrogenism, we need multiple and individualized management. First, education is very important. In China, we often see this situation. We have many patients. In the morning, I often give them the education. We also give multiple and individualized management for nutrition. We measure the total body composition and ask them the dietary and give them nutrition guidance. If the patients have a very significant sign for hyperandrogenism, I give them anti-hyperandrogenic treatment, such as if PCOS patients, we often use diene 35 for treatment. If the patients is before treatment and after 1 year's treatment, the acne disappeared. This patient is alopecia. After 6 months treatment, his hair is recovery. We also try to do some clinical trial. The management, obesity, hyperandrogenism, or insulin resistance. We use Orlistat, is O, and metformin, M, diene 35, D. We give them 3 months treatment compared with baseline. Every group, we have 60 patients. It's prospective randomized placebo-controlled study. After 3 months treatment, we can see the weight is decreased. The Orlistat plus metformin and diene-35, the weight loss is significant, is much more. But Orlistat and the diene-35 also good. The decrease of waist circumferences also is the Orlistat plus diene-35 also decreased is very well. And SHBG, this word is wrong, is increased SHBG. The OMD group is much higher than other groups, but all is increased. The FAI also decreased. The Orlistat plus diene-35 is the best. The total body fat percent also is decreased. Orlistat, metformin, and diene-35 is similar to Orlistat plus diene-35. This research, if you want to know the detail, you can see these two. We have published these two journals. Is Gynecologic Endocrinology, and this journal you can is published is online and also printed. So we also do some research about the peer management is very important for pregnancy outcomes of PCOS patients. This also we just recently we published in Fertility Sterility. This research we comparing the risk of adverse pregnancy outcomes of Chinese PCOS patients with and without anti-androgenic treatment. 6,000 healthy women, we call Group A, were selected from more than 24,000 pregnancy women by randomized sampling. 450 PCOS patients without EE-CPA treatment is we call Group B. 225 PCOS patients with 3 months treatment with EE-CPA we call Group C. The prevalence of pregnancy diabetes, pregnancy-induced hypertension, and premature delivery were significantly higher in Group B. Is PCOS group no treatment. You can see the yellow bar is PCOS patients no treatment. Diabetes, hypertension, and premature delivery is much more higher than PCOS patients Group C have 3 months treatment. So PCOS patients are more likely to develop diabetes, PTH, hypertension, and poor delivery. So treatment with COC, such as EE-CPA, was associated with the lower risk of GDM, PTH, and PD. For this research, we have got in the World Congresses, we have got a Best Practice Award. The Human Reproduction Congresses, and this year, in March, the Gynecologic Endocrinology World Congresses. For this season, we have very good clinical results. Our cycle pregnancy rate is more than 35%. 3-cycle pregnancy rate is more than 68%. For this reason, patients send us flag. It means thanks for doctors, because after the treatment, they have healthy baby is one. They also have baby group. And healthy in short term with my clinic is a monkey year. A short term, my patient group sent me this photo. It were all healthy. For this reason, I thanks all my team and my teacher, Professor Milk, and my government give our support. Is our Vice Primary Minister Marquet send give the Great War Friendship Award to Professor Milk, and also Chinese government Friendship Award. Our Primary Minister Li Keqiang thanks Professor Milk, and our Beijing government also last year gave Great Wall Friendship Award to Professor Milk. Is our mayor, and thanks very much for our international expert team. I think many important speakers in this Congress have visited China, attend our Congress, including the chairman, President Genazzani as a GE, also is our important experts. It's thanks to Chinese doctors. It's all my presentation. Thank you very much, and welcome all of you to China.
So last night when I arrived in Vancouver, I found out that the hotel was oversold and I had to be moved to the downtown Westin by the waterfront. And I was wondering, why I had been invited to speak at this Congress, and I passed a gigantic hotel that had a big name on top called Trump. And at that moment, I realized probably because everybody at this meeting is wondering what Americans are thinking. So while I may not be able to give you any insight at all into what Americans are thinking about politics, I hope to give you an insight into the position of the Endocrine Society, which is largely but not exclusively American, but we have a large presence there, and some of the recommendations are influenced by what's approved in America. But what I'd like to do in the next few minutes is walk you through some of the reasons behind the Endocrine Society guidelines. These are my disclosures. And Dr. Davis couldn't have set me up better if we had conferred about it beforehand, because we have many of the same items that we're going to touch upon. I want to go over with you what we know about androgen changes across the transition, complementing what you've already seen, and help you understand why it's so hard to make biochemical diagnoses. And the importance of that is that if you're really not sure what you're measuring, or we think we have cellular effects, then what's the only way to get information is really through clinical trials. Do patients feel better? So we really have a tremendous call for research in this area that is sorely needed. But in the meantime, we have patients who want to be treated. So one must balance the benefits against the potential harms and define where the places are that we may want to use androgens. So these were the possible benefits of androgen therapy that the Endocrine Society considered. There's quite a bit of literature about ovarian rescue for women, especially those with diminished ovarian reserve, one of the most frustrating problems in reproductive endocrine practice. Improvements in fatigue or in sexual function in women with hypogonadotropism, and this is largely a hypopituitary crowd that has been treated. Improvement of menopausal symptoms, and finally, the one that's the most difficult to prove is prevention of chronic disease. So I'm going to cover some of those issues. And as Dr. Davis showed you, androgen biology in women, we have 3 ways that you get androgens. The ovaries are a fairly important source. They peak in the 3rd decade of life, so really important to remember that a lot of the decline in androgens that happen in women happens even before the menopause transition. And the free testosterone index, problems acknowledged from the prior speaker, does not drop further as women complete their menopausal transition, but where we do see a change is in adrenal androgens. So this is one of the reasons they have been of interest. And I just love this slide. It's going on 20 years old, but it really shows you a number of different adrenal androgens all declining throughout adult life. So the x-axis is ages 20 to 80, and it's a cross-sectional study. So you're looking at different populations at different age groups. And in both men on the left and women on the right, for each of those letters, you see decreases in DHEA, DHEA sulfate, and other adrenal androgens, some of which are too long to pronounce and would end my talk by the time I got through them. But there's a problem when you look cross-sectionally and not longitudinally. And as Ruth Freeman, who recently retired from practice at Einstein, used to say, if you try to make longitudinal conclusions from cross-sectional data, you would conclude that the population of Miami, everyone was born Cuban and died Jewish. And that's not really how it works there. So when you look at the cross-sectional studies, all you see is this inexorable decline, but when you look longitudinally, you get a different story. So this is a compelling place where, again, a call for investigation is important. But in the SWAN study of women's health across the nation, we see DHEA sulfate rise in association with the late menopause transition and remains elevated for a couple of years afterwards. And that happens in about 3/4 of the women in the cohort. We see it if they have their ovaries removed, as well as the women with natural menopause. And it seems that the adrenal is activating at that point. It's not clear why, whether this is related to a rise in LH at the time, which is our leading hypothesis, but clearly it may be telling us something that we need to know. And is it helping some women and not others with symptom control, some of the things Dr. Davis talked about? Does it somehow even out the other hormonal fluctuations that are happening at that period of life? So this is the cross-sectional data. This is from an earlier, the longitudinal data, from an earlier study in SWAN. We've since published several follow-up studies on this, but when you look at women prior to any sign of the menopause transition or in the early stages, DHES, looks like it's on that downward trajectory, but when you organize it by menopausal stage, the late perimenopause, when they have at least 60 to 365 days of amenorrhea, and the early post, the first couple of years, there's an increase of DHEAS, that is not shabby. And given that the molar concentration of this hormone is relatively high, its conversion products may well be important and worth looking at a little more closely. One of the other areas that androgens are thought to be important are, does early menopause cause androgen deficiency? That causes problems. And as you've heard already, measuring testosterone to try to decide if a woman is androgen deficient has a number of problems associated with it. So again, you've got to look at the patient. But the NIH group with Sophia Kalantaradou found that there was about 1/3 of a drop, so 30% deficit in circulating testosterone, and this is RIA, which has some caveats, in women with primary ovarian failure. But when you give back exogenous testosterone, they did not see any benefit. And they gave a fairly reasonable dose of exogenous testosterone. So again, looking at the clinical endpoints, we have a lot of theories and evidence that associates low testosterone with different disease states, high testosterone with different disease states, or healthy states, but we've got to make sure that we have our endpoints together. And in this case, it didn't seem to prove out. And I'm not going to dwell much on this, but because Dr. Davis already covered it, but when you look at the discrepancies between assays, immunoassays versus mass spectrometry, you can see some pretty big differences. So when you have two identity curves, this should be a perfect agreement. You've got it drifting up. If we think that DHT, the non-aromatizable sort of end androgen is more important, you're going to be wrong more than you're going to be right. So it's extremely important that we come up with better ways to measure what we're looking at. One of the other areas the Endocrine Society talked about was possible ovarian rescue. Because testosterone is essential and theca cell testosterone is so important for follicle function, do androgens activate the existing follicles, especially when the numbers are low? We know that in aging women, when the follicle numbers do get low, FSH goes up, aromatase goes up in the follicle, so per granulosa cell there's more aromatase. But if you don't have enough substrate, you're still going to be in trouble. Is this one of the reasons for reduced fertility or fecundability in those aging ovaries that we sometimes try to get to work in our infertility patients? So can androgens supply precursors? Well, it used to be thought that testosterone was atretogenic, that too much testosterone made the follicle become atretic, but that does not seem to be the case. And in some monkey models, a short course of testosterone increased ovarian size and follicle number, didn't increase preovulatory follicles, but these types of studies raise the question as to whether it would be helpful, and there have been a large number of clinical studies that have looked at this, and I've summarized them here. We've got the yes, it helps, and the no, it doesn't help. Most of the yes, it helps studies are case series. They don't use testosterone, they use DHEA as a precursor. So again, difficult to measure exactly what's being converted to testosterone and where that's happening. Many of these are non-randomized, so non-randomized control trial with an outcome of pregnancy rates. Small sample sizes, 22 women with primary ovarian insufficiency. The outcomes were more follicles seen on ultrasound. And the Gleicher group in the States has been one of the most effective proponents of giving DHEA to women. They have multiple endpoints. Some of them are live birth rates. Many of them are just embryos that are produced in IVF. None of them are randomized, and David Barad, who's a member of that group, who's a friend of mine, insists that he cannot do a randomized trial because patients would not agree to it, which I can understand, but without that, we just don't have the evidence we really want to see. The randomized trials here, this was 50 looking at oocytes, 99 women, again looking at oocytes, so do you actually get more eggs if you pre-treat with androgens? Most of these are small numbers, not to be super convincing, but if you look on the right side, most of these are randomized trials, most of these are not. So again, this led the Endocrine Society to be a little suspicious of the weight of evidence to see that it would make a difference. And one of the other conundrums that we live with is we all are pretty comfortable, or we're all consistently, let's just say we're all the same level of uncomfortable, giving hormones like estrogen and progesterone back to menopausal women. But should we be adding androgens? How will they alleviate menopause symptoms? I really don't want to compete with my colleague to the right who really knows more about this than probably anyone. And there's certainly a case, and there's a compelling argument to be made. But again, do we have enough of the data that we need to make a recommendation? Androgens can be precursors for estrogen, so they're available for aromatization. So when I see studies that just give testosterone to women and look for improvements in different endpoints, it always makes me wonder whether we're just looking at more bioconversion to estrogen. Unlike Dr. Genazzani, who I think said testosterone is the most important hormone, I tend to be more of an estrogen supremacist here, so, and think that may be playing the biggest role. But there is certainly evidence, and you've seen some of it earlier, on symptoms, libido, cognition, insulin sensitivity, and immunity. They've all been proposed. There are some studies that are well-designed that show positive effects, yet there are others that do not. So again, we remain a little bit confused. So for possible benefits on these aspects of health, which are very common complaints among menopausal women. How many of you have patients coming in with these complaints and you're never really sure, is this really something that estrogen is going to magically help? Maybe not. Or you treat them and they're not completely better. One wonders, would they be better with a little bit of androgens? And you do see in some subsets of patients some tantalizing evidence that there may be benefits on mood. In oophorectomized women, I think you have the best case. There are very inconsistent findings with DHEA, but a little more so with testosterone. So finally, when we talk about the prevention of chronic disease, this is a very tricky area because there's two ways to look at this. So one way that you can look at it is to look at large populations in either cohorts or in cross-sectional studies and to associate ambient androgens and link them to outcomes in this type of a design. But what are your endogenous androgen levels telling me about you? Especially if some of them are coming from your adrenal gland. They may be saying other things about your state of health that don't necessarily have that much to do with your androgens, but has to do with your state of health. So extrapolating this to randomized trials is really kind of where we are now. And it's a tricky business because few of the randomized trials are able to address these issues. They're very hard to do. If you want to look at things like prevention of chronic disease, you need a very long-term study. So it's extremely challenging. And it's a tough field to be in because your biological plausibility is often assailed. We do know from association studies, and this is one that we had done from SWAN more than 10 years ago. This is a cross-sectional look at our data. I'm going to show you the longitudinal ones later. And these are pretty commonly seen in other similar types of studies. Increased, in this study we looked at free testosterone index, is linked to lower sex hormone binding globulin, greater insulin resistance and metabolic syndrome. And here was a fairly impressive odds ratio, so that was 2.6. This is about 3,000 women. Increased BMI, waist-hip ratio, and waist circumference. And those correlations were moderate. So those were the negative correlations, but we also saw some tantalizing positive correlations. They are small in terms of effect size, but they are there, and they repeated in the longitudinal cohort. So better self-reported health, less depressive symptoms, and increased reports of desire and arousal in the women with the higher free T index. So in the SWAN longitudinal follow-up study done a few years ago by John Randolph, again, about 2,000 women that we were able to retain in that cohort, testosterone was associated with some sexual endpoints, increased masturbation, again, small but significant effect, and increased desire. DHEA sulfate, similar associations. And estrogen was not associated with any of those sexual domains, and that was using, it's an immunoassay, but it is cranked to be quite sensitive. So it's sensitive down to about 6 picograms per mil, and we have not published this yet, but its comparisons to mass spec are actually quite good, even at that low level. One of the other things we saw that was interesting in the follow-up study was that FSH was negatively associated with some aspects of arousal and desire. So it raises another question of whether our long-ignored gonadotropins that we've paid no attention to because we think they just do what the ovary is telling them to do, may be playing some kind of independent role here as well. So I think it's one of the things we need to think about when we look at menopausal women. So what's the downside? Why don't we just use it and worry about the consequences later? Well, we do still have limited long-term safety data. We have a 4-year open label extension of the 300 microgram transdermal patch in about 1,000 women. It looked good. The Aphrodite study had a 2-year follow-up with a 4-year open label extension. The biggest side effect seemed to be hair growth, was a little more prevalent, 30% versus 23% in the placebo group. So that's not always a desire. And a concern that has been raised is a concern of breast cancer. And this is a very muddy, difficult area to sort out, but it is a great concern, and I believe it's one of the reasons that the U.S. has been so reluctant to approve testosterone. When you look at associations, the Nurses' Health Study, there was a 77% increase in breast cancer in women who use testosterone with estrogen. So that raises concerns, but again, association, your causal inference is limited. In the Aphrodite study, there were 4 breast cancers in the active treatment group, detected pretty long after the end of treatment, so their linkage to the actual treatment is very difficult to be sure occurred, but there were none in the placebo group. Not the endpoint you want to have a spurious correlation with, but. And the other potential uses for androgens were also evaluated very carefully in the Endocrine Society statement. And overall, the conclusions were that you just couldn't get enough data on one side of the equation to come out in favor. So cognition, very important area. You've seen some data on this. There are other studies that are negative. Bone health, definitely all of these areas worthy of further investigation. Body composition, I think you can make one of the best cases for testosterone because we know, being a baseball fan, I know what it does to help the hitters, and being an endocrinologist, when they had the testosterone doping crisis in the United States, and unfortunately I'm a Yankee fan, and you saw all the Yankee sluggers coming up to bat, and the announcers would say, yeah, you know, ever since so-and-so developed this pituitary problem, and you could just see the guy's muscle mass just going away. He couldn't hit home runs anymore, and they were calling it a pituitary problem, but obviously he had stopped doping with testosterone. Mood also, I mean, clearly in men that use testosterone or in women that use it for bodybuilding purposes, and this is very supraphysiologic, they do report differences in mood. And in hypopituitary people, another area where I think it is worthy of further investigation. But the data overall, taken in their totality, are mixed. The reviews indicated that there is a high likelihood of publication bias. So that's the other thing that I think you have to be very careful about in this field. When you see a positive effect of testosterone on an endpoint like sex, this is headline news. Everybody wants to pay attention to it. The negative study gets buried in a journal or never gets published, or because it won't lead to a pharmaceutical application, just doesn't, no one bothers. So those issues, the confounding with other conditions, the inadequacy of, separating what's endogenous from exogenous. Some studies lump together, how did your testosterone get high? If you were taking it exogenously, is that controlled for in all these observational studies? Well, the answer is no. So that all clouds and muddies the water and led to caution in general. So when we get to testosterone, the Endocrine Society made a few considerations. Non-oral testosterone is preferred, but it is not FDA approved for women in the United States. And the dosing is not well understood for indications other than hypoactive sexual desire disorder. DHEA is out there. That is approved now as a vaginal preparation. But its supplementation has overall been shown not to be effective for sexual function in terms of sexual desire and motivation. Clearly, it has been proven and was approved for genitourinary syndrome of menopause, particularly for dyspareunia. Inconsistent benefits for mood, for well-being, for cognition, for insulin sensitivity and immune function, although lots and lots of hope for that. In men, there are some more consistent benefits, but, and is there a downside to using DHEA? Well, some studies have shown a lowering of HDL. Really, the bulk of them have not, so there seems to be a really minimal downside. Transdermal testosterone, there are some minimal and inconsistent lipid changes. So over the short term, neither of these seem to be particularly liable to cause harm, and if they do cause an inconvenient side effect, it's usually hair-related. So the Endocrine Society Clinical Guideline in 2014 recommended against making a clinical diagnosis of androgen deficiency because we lack adequate ways to measure androgens present. So if we measure circulating androgens, the argument can always be made you're not measuring tissue levels of androgens, yet we are not in a position to be biopsying women and looking at that conversion until we understand the pharmacogenomics a little bit better. I think we just don't really have a way to do this. So all the more important to be very careful and very clear about the symptoms we're looking at and the improvements we're looking at. So the Endocrine Society recommended against using testosterone for infertility indications because the data were just not clear and consistent enough. Against using systemic DHEA for women because the indications are not adequate and efficacy and long-term safety data are lacking. Against routine treatment of women with low androgen levels, and that really goes back to the first point because that's not the best way to make the diagnosis. But in these particular cases, despite some well-done studies that look like they were helpful, there are other studies that do not look like it's helpful. So enough is not known. And because the recommendations say against, lest I sound like Debbie Downer here, it doesn't mean that none of this is worthy of further investigation. Really, all of it is, and that's why we're having this symposium. But for regular routine clinical practice, this just shouldn't be done. It should be done in a clinical trial setting. So the Endocrine Society did yield on one point, so we didn't say no to everything. There is enough data out there to say that testosterone for women with well-diagnosed hypoactive sexual desire disorder was a reasonable intervention to try. So a 3 to 6 month trial was what is in the guidelines. Titration should be to mid-normal premenopausal testosterone levels, and now with most mass spec assays being commercialized in the United States, you can actually measure peripheral testosterone with reasonable accuracy depending on your lab. T should be measured at baseline after 3 to 6 weeks. Make sure that you're giving enough, and it should be reviewed and monitored for excess. And the most important thing about this is it should be stopped if it's not effective. I have a number of patients that come to me with menopausal symptoms who have been on long-term testosterone. They don't know why. And I said, well, what is it doing for you? Tell me how it's helping you. And they say, I don't know. So we stop it, and they don't notice a difference. But for the women who do, you'll have to rip it out of their cold, dead hands, and then you can kind of have the discussion with them about all of the unknowns, because there are really no great safety and efficacy data that are available for long-term use. So patients do need to do some shared decision-making about those aspects of use, and I find it very useful clinically to trial it first, because only if it's effective is it worth having that discussion. So in summary, the role of androgens in women's health, absolutely worthy of further study. If you can alleviate some of the symptoms in women with early menopause, if you could help ovarian rescue, if you could improve sexual function or prevent chronic disease, these are pretty big benefits. So they absolutely justifies further examination. However, the current data do not favor routine, and again I say routine treatment, with androgens in a non-experimental setting for all of these indications except for hypoactive sexual desire disorder. And with that, I thank you for your attention.